Our final presentation is by Dr. Roman Schinder on the use of steroids in orbital cellulitis.
Thank you. I want to thank Jeremiah and Rich again for the kind invite and for hosting what so far has been a fantastic meeting, so kudos, guys. We're going to start with a question. Okay, I don't think this is my question, but I think it'll do. So the question is, do you routinely use steroids in treating orbital cellulitis? 1 for yes, 2 for no. Okay, so almost 50-50. That's a little bit surprising to me, but that's good. Let's go to the next one. How do you now treat a typical child admitted with orbital cellulitis? A, just intravenous antibiotics. B, IV antibiotics and steroids upon admission. C, antibiotics and steroids, but you give a day or two for the antibiotics to give you some clinical improvement. Or D, antibiotics and steroids once the serum CRP reaches a certain threshold. Okay, so it looks like most of you want some antibiotics to help you, and then you finish off with steroids. I have no financial disclosures. We've done through that. So what I'd like to do today is first go over and review orbital cellulitis, much of which you guys will probably already know. Talk about conventional treatments that have been around for a while. Talk about other services who have been a little bit earlier to the party than us about using steroids in acute infectious processes. Talk about the literature that we have now where folks have used steroids with some success in orbital cellulitis. And then talk to you about our personal experience we have in Brooklyn at our tertiary center. So as a review, we will all remember that orbital cellulitis is more commonly seen in children. It is almost always the direct extension from adjacent ethmoid sinusitis. We know the typical signs and symptoms. These children are sort of sick in appearance: fever, leukocytosis, proptosis, and the other ones listed there. Luckily, rarely is vision compromised or other serious complications such as cavernous sinus thrombosis or meningitis seen. I think CT is universally needed to examine the orbit and the sinus radiographically, and then we lean on our otolaryngology colleagues to take care of the sinusitis when present. As a review, the orbital septum in this diagram with the skin and underlying orbicularis stripped away, we can see is a good protective layer that originates from the orbital rim and separates the pre- and post-septal compartments. Seen sagittally, you can see there right behind the septum, we get into the orbital tissues and the fat. So typically, we know what happens. The children get admitted, they get broad-spectrum intravenous antibiotics. Serial exams are important, so the residents or you guys are seeing these children at least once a day, sometimes more, depending on clinically how they're doing. And prior papers sort of guide us on which children can benefit from surgical drainage of their sinuses and or orbital abscesses. So steroids, controversial still to this day. There's really no standard of care, but let's see what's been done in the past and maybe what we can do going ahead in the future. What can steroids do for us infections? Well, we all know that steroids, prednisone, intravenous steroids have anti-inflammatory effects. What we should also remember is that acute infections increase our acute phase reactants, cytokines, inflammatory markers. And if we remember the medical school pathophysiology, it's those inflammatory markers that give us many of the signs and symptoms in acute infection. If we look at literature from neurology, neurosurgery, and our ENT colleagues, they've been using steroids for these two main infections in the past. Meningitis, so if you read the papers listed there, the mortality rate is decreased when they use steroids, and other neurological sequelae such as hearing loss is also not as bad. If we look at the ENT literature, and this one is important here, they commonly use steroids in acute bacterial sinusitis. Less congestion, less scarring, the kids do better. And why is this important? Well, orbital cellulitis in kids almost invariably comes from ethmoid sinusitis. And the treatment of that sinusitis is paramount in getting these children better. So it makes sense that steroids may help us here. But there's hesitation, right? You guys remember in medical school, if you had similar training to me, what if the steroids make things look better and feel better, but it's actually masking serious residual disease? We don't want to immunosuppress a child who's fighting an acute bacterial infection, do we? That's a no-no. That's why some folks are hesitant, especially in my experience, pediatricians and ID specialists. Let's look at some past papers. There are several, and they differ whether they're treating children or adults, giving either oral or intravenous antibiotics, and whether those are given on admission or later on after 1 or 2 days of antibiotics first, or if you wait for CRPs to drop down below a certain threshold. What do these papers tell us when looked at as a whole? They accelerate the clinical improvement of the children and allow them to leave the hospital a little earlier. Is that a big deal? Well, let's see. You decrease risk of nosocomial infections, you get children back to school earlier, you get the parents back to work earlier who have been tending to the children, and they're in a more comfortable environment, getting better at home, rather than the hospital, healthcare costs, et cetera, et cetera. One study thought that it also showed the decreased need of intravenous antibiotics on discharge home. They were relatively safe. There was no case of progression or recurrence after the child went home. The way I think about it is you can treat a child with just intravenous antibiotics and they'll usually do fine and get to their baseline of health. If you do it with steroids, they also get to that same endpoint. They just do so a little bit faster. So let's talk about some of our experience over at SUNY Downstate in Brooklyn. We published this paper last year in OPRS. Our purpose was very simple. We thought about giving children intravenous antibiotics and steroids right when they got to the hospital on discharge versus the control with just standard conventional IV antibiotics alone. This was a prospective comparative interventional study. It was about a 5-year time period from 2010 to 2015. In total, 43 children were studied with orbital cellulitis that was diagnosed based on classic clinical and radiographic features. On admission, everyone universally was given the same broad-spectrum intravenous antibiotic coverage. And in all cases, the parents of the children were offered intravenous steroids, irregardless of severity. There was no triage. You came in, it was offered to the children with abscess, without abscess. It didn't really matter to us. Parents were told that this was not a standard of care therapy, and they certainly had every right to refuse. We chose to give IV dexamethasone at the dosing pattern seen there, 0.3 milligrams per kilogram per day, divided Q6 hours for 3 days. We chose this because in the pediatric literature, this is the dose given in just general inflammation. We wanted to give enough to see a clinical benefit. We thought 3 days worth would do that, but not a duration where we would run into some of the side effects, gastritis, growth suppression, et cetera. So the parents who said no thanks, that was our control group. So they just got antibiotics alone. Whenever they needed surgical drainage based on past reports, they had that done. Kids who were excluded, anyone who had intracranial involvement, we did not give steroids. Anyone who came in immunocompromised for any reason did not get steroids. If there were any contraindications to steroids, if we presumed a fungus, or anyone with a follow-up of less than 3 months. After some time in the hospital, the treating teams agreed on when to transition to PO antibiotics. And 24 hours later, if they remained showing good clinical response and they were afebrile, the teams agreed to discharge them home. They were carefully followed universally within the first week and at least for 3 months after that. So here are our results. We had 19 males, 24 females with a mean age of about 9 years. 2 groups. The steroid group had 28 total children, 13 girls, 15 boys with a mean age of about 9. Of those, almost 20% had surgical intervention for sinus and/or orbital abscess. The other group with just antibiotics alone, 15 kids, 6 girls, 9 boys, mean age of about 8 years. And again, similarly, about 20% required surgical intervention. Let's look at our results. If you take a look at the first row there, hospital stay, in line with past reports, had a statistically significant difference. So if you got steroids, you stayed in the hospital for about 3.8 days. If you didn't, you stayed longer for about 6.7 days. If we looked at folks who required surgical intervention and drainage, they stayed a little longer. They had to recover from the OR. With steroids, 5 days. Without steroids, just over 7 days. If all you needed was medical treatment without surgical drainage, you stayed 3.6 days with steroids, or about 6.5 without steroids. We did not see any correlation between age, gender, or white count among our data. And you can see at the bottom, the follow-up was pretty robust, 6.5 months with the steroid group, almost 8 months with the antibiotics alone group. If you want to look at it in a bar graph, you see what I just said. Kids with steroids, if we look at the first one with surgery, they stayed shorter. If it was just medical treatment, they also stayed shorter. And you look at overall means, and those were all statistically significant. Side effects, luckily for us, they were few and mild, as judged by the treating team. The most common one that we saw was hyperactivity in 3 children, or 11%. 1 child had some difficulty sleeping. None of these were deemed to be significant enough to halt treatment, and the steroids were continued. We did not see any children who had progression of disease once the steroids were started, nor did we see any child or an increased bump in need for surgical intervention or readmission after discharge. All of the children went back to their normal state of health and their ophthalmic examinations. Luckily, no visual compromise or sequelae. Mean follow-up again, 6.5 months for the steroid group, almost 8 months for the antibiotic group. So that was our published data. That ended several years ago, and what I can tell you is unpublished data. In the last 3 years or so, we have even more children that we've done this for. And so this group has a follow-up of 4.3 months. We've recruited 32 more children treated in similar fashion, mean of about 8 years old. These children got steroids and antibiotics. Their hospital stay, when you look at all comers, was 3.4 days. Folks who did not need surgical intervention stayed for 3.1 days. Kids who needed surgical drainage stayed a little longer for about 4 days. Side effects, again, luckily, mild, only hyperactivity in 2 children, deemed not significant enough to discontinue the steroids. All children, again, went back to baseline without any visual compromise or ocular sequelae. So when you look at all the data, published and more recent unpublished, we've had 75 kids in Brooklyn treated with steroids and antibiotics intravenously on admission. They've all luckily done okay. It's been safe and effective, at least in our hands. Let's look at some clinical examples. On admission, a boy with a left orbital cellulitis, 3 days later, only needed medical management after steroids. Here's a girl with right-sided cellulitis. She did need surgical drainage, going home after 4 days. Last one, on the left side of a girl, 3 days later, going home with only medical therapy. To me, I don't think I would have had this quick of a response with just antibiotics alone. And anecdotally, when we see the child and the parents, 1 dose many times after starting steroids, the kids are acting more themselves. The parents are quite happy. They tell you the child is regaining more normal function, energy levels, and they're not quite as septic appearing. So in conclusion, we feel that this may be the first study to recommend intravenous steroids upon admission with antibiotics with a standard dosing regimen. We think it's safe. We think the children get better faster and can leave the hospital sooner. The most significant benefit, again, they get better faster and they don't have to lay around the hospital as long, and they get back to school and the parents get back to work. We think it's pretty safe. We haven't seen any children thus far progress because of their immunosuppression. Side effects so far have been mild and well tolerated without discontinuation of the medicine. And again, I think this shouldn't be a knee-jerk response when someone comes in with orbital cellulitis. You should make sure the children aren't immunocompromised or have a potential fungus where this could really not be so good. And I think also important, the short-term dosage of steroids. We only gave 3 days worth. We think it's okay. The longer, certainly, the higher the chance of side effects from the glucocorticoids. So in the future, where do we think this is going? I think probably it's going to require a multi-institutional, prospective, randomized, blinded study with a control group to better elucidate how is best to give the steroids, the timing, the route, the dose, and duration, where we can make some more conclusive remarks from this. Okay, so let's end with a question. Hearing the talk, how do you now plan, when you go back to your practices, to treat a typical child admitted with orbital cellulitis? Oh, we've made progress. Okay, good luck. Good luck to everyone. Thanks for your attention.
Thank you.